We have a lot of challenges, obviously, in pediatrics. Our patients will see the disease longer in the absence of a cure. If we treat them with a medicine, especially medicines or nutritional therapies that work, they're going to be exposed much longer than adult patients to this treatment. The risk of adverse events could be unique to pediatrics, for example, steroids and growth or bone density. And also, there is an inherent risk of a lot of the studies that we may do for those patients, not just anesthesia or endoscopies or colonoscopies, capsule endoscopies, enteroscopies, but also radiation from the multiple use of CTs. And a developing body with multiplying cells at the same time could be more sensitive to the effects of radiation at any point in time. We also will keep in mind that the presentation of pediatric Crohn's disease in particular is more severe than adult onset Crohn's disease. Just as an example, a third of our patients with Crohn's disease will present in growth failure. So it emphasizes the need for not only early diagnosis, but also early effective therapy, and that would be what I hope to cover today. We do have a lot of burden, a lot of opportunity in IBD. Obviously, we have to define what our goals of therapy are and stick to those every single time we see our patients. And the strict definition of remission should be the absence of symptoms, absence of any growth slowdown, a complete normalization of labs, because that goes along with a deeper degree of healing, normalization of bone density, support in achieving complete normal psychosocial development and growth. Also keeping our patients steroid-free, and I'll explain why in a few slides. And also some focus on mucosal healing and the concept of changing the natural history. We also have to keep in mind that as much as we'd like to think so, IBD does not end at the age of 18 to 21 years when we transition our kids. And also keep in mind that early IBD response to therapy is different. This is shown in pediatric data, this is shown in adult data, and to ignore this fact as a pediatric gastroenterologist treating IBD is a huge, huge mistake. Now also, changing natural history may depend on how the early treatment of IBD goes, and that's really a window that we can capitalize on in pediatrics, since 1 out of 4 individuals with IBD present in the pediatric age group. Now, a responsibility that falls upon us in pediatric IBD is also the proper use of these medications. We all know that if you treat with an approach of start-stop, this could sensitize the patient to the medication and you're burning a bridge. If you underuse a treatment that was not effective, that takes one option off of your hands as an adult provider when you receive those kids. So it's a responsibility to use the best medicine, the best treatment at the best form before saying this worked or didn't work, so we keep all our options open when you receive those kids later.